Hello and welcome. I am Cassidy Avila with the Center for Optimizing Rural Health, also known as CORE, and I'm pleased to welcome you to this webinar on service lines in rural healthcare, a bottom-up approach. We're excited to have three excellent speakers from PYA, a national top 20 healthcare management consulting firm, presenting on this topic today. I'm going to introduce our speakers in just a moment, but first, just make a couple of housekeeping notes. We are recording the webinar, and I will share that with you guys. Give us about 24 hours to get it posted to our website, and then you will receive an email from CORE with a link to the recording, as well as a copy of the slides. We will have time for Q&A at the end of the presentation, but you may go ahead and drop your questions into the chat box during the webinar. And
for others to join.
Mute someone. There we go. And I will make sure that the PYA team addresses them during your Q&A. You'll also have the opportunity to unmute yourself during Q&A and ask your questions if you prefer that. It is now my pleasure to introduce our speakers. I'm going to begin with Brian Fuller, a healthcare consulting principal at PYA. In his nearly 3 decades of providing advisory services to clients, Brian has led health systems and provider organizations through scores of strategy engagements, including enterprise growth, mergers and acquisitions, clinical service line strategy, and network development. Throughout his career, Brian has written and presented on a variety of contemporary topics for national organizations such as the American Hospital Association, the Governance Institute, the Healthcare Financial Management Association, and numerous state hospital associations. Prior to joining PYA, Brian was a national partner within Optimum Advisory Services, and he received his Bachelor of Science degree from the Ohio State University and his MBA from Duke University. Also presenting today is Marcy Spent, a senior manager within PYA's strategic planning team. For nearly 2 decades, Marcy has provided strategic guidance and advisory support to physicians and hospital systems, helping them meet their business goals and implement system-wide opportunities. With over 12 years focused on the development of coordinated and comprehensive oncology service lines and 10 years working within multi-hospital health systems, she brings specific skills and insight into implementing highly actionable plans in the most complex environments. Marcy offers expertise in strategic planning, market assessments, new program development and implementation, program optimization, physician and hospital integration, multidisciplinary team facilitation and accreditations, quality metric development, facilities planning and programming, and more. Marcy holds a Bachelor of Science in Business Management from Fairfield University and a Master of Business Administration from Emory University's Boyd Wada Business School. She has a Quality and Process Improvement Black Belt certification from Mercer University and is a member of the Association of Community Cancer Centers. And also on the call today presenting is Emily Oates, a Senior Staff Consultant for PYA. Emily provides strategic and transaction advisory services to hospital and healthcare clients. Her strategic advisory work focuses on the assessment of market and organization environments, identification of strategic challenges, and resolution through strategic plan management. Emily also provides comprehensive project management skills to support clients with large transformation and transaction integration projects. We are exceptionally pleased to have you guys with us here today, and I'm going to go ahead and mute myself and hand it over to you. It's all yours.
Thank you, Cassidy, and thank you, everyone. We're pleased to be here speaking to you on this important topic. Just a brief bit of background on PYA as a firm. I don't know to whom we're familiar. We've been around for about 40 years. I think actually this is our 40th anniversary. We're headquartered in Knoxville, Tennessee. We have offices, as you can see on the slide, around the country. We are one of, I think, the few remaining independent consulting firms owned by the consultant owners of the firm. We're largely a healthcare consulting firm, probably 75–80% of our business. We also do some accounting and tax work, but I think we are, building our brand and trying to build our brand as a healthcare consulting firm. Interestingly, in 2022, we started the Center for Rural Health Advancement. It's a topic that's near and dear to our hearts, and one that we felt needed more attention in our space. That is headquartered out of our Helena office in Montana. There's a lot more information on that on the website as you find yourself having time to take a look at it. But without further ado, we'll jump right in. I'm going to ask whoever has control of the slides to go forward one, please. So what do we hope to achieve today? We want to talk about clinical service lines in the rural setting, clinical service lines really as a means to differentiate legacy provider organizations in an environment that we'll talk about, in which means of differentiation are increasingly difficult to find for those types of organizations. I'm talking about hospitals and health systems writ large, but rural systems particularly. We think that service lines represent an opportunity for those legacy industry participants to differentiate themselves in the market and continue to be a meaningful part of the healthcare delivery continuum within those. We have come up with an approach which we have shared with our clients and used with many of them, and Emily will talk us through that. But we're hopeful it's very pragmatic, very doable, but we'll get you to the right answer around whether to prioritize service lines, if so, which service lines to prioritize, and then how to move forward. And then lastly, we're going to talk a little bit about the considerations associated with these service lines, and that is financial, operational, organizational. We'll get into all of those. So 3 parts. I will start with the background and just kind of our thinking on service lines. Emily will walk us through our approach, and then Marcy will jump in here at the end with a couple examples of some situations that we think are relevant to the topic. So starting out about service lines, I think the place to start is to define what that is. We think of it in terms of what it is functionally. So a set of services utilized by a patient with a given diagnosis or disease state. I think the important things as we think about service lines is that they are, number one, patient-centric and patient-focused. Number 2, they span the continuum of care. It's not just a hospital, not just a service line within the 4 walls of the hospital, but that it crosses into the outpatient space, into the post-acute space. Is incumbent upon us, I think, to incorporate support services into the delivery of the service line as well. And it is something that, in order to really make it work, we feel needs to have accountability within the organization. So whether that is accountability for quality, for operational metrics, and or for financials, this is a business that we're running, and we think it needs to be identified as such and treated as such by organizations. And if done so correctly, again, can be accretive to an organization, can improve quality and access in a given market, can improve quality over the continuum of services, and can really help to differentiate hospitals. One more. We don't need to beat you guys over the head any more than you already have been on these next 2 slides with respect to the industry trends facing legacy hospitals. All pretty significant headwinds right now. If we're even coming out of the inflationary environment and moving and hopefully addressing our workforce shortages, it just seems like there's an endless litany of issues that are coming at us. And in today's environment, most of those issues are trending negatively for traditional acute care hospital providers. So whether it is how we're funded, how much we're funded, what's paid for our services, whether it is how care is delivered and where it's being delivered and how well positioned those legacy providers are to deliver that, whether that's a shift from the inpatient to the outpatient setting, whether that's a shift from in-person care to virtual care, whether that's a shift from something that was formerly reimbursed in one fashion that's going to be reimbursed in another fashion going forward that's less advantageous to hospitals. All of the things that we had traditionally relied on that formed our economic model are changing, I think, more rapidly and with more likelihood and certainty that they're going to change fundamentally than at any point in my 3 decades in the consulting industry serving providers. On top of that, we live in an environment in which finally, I think, the rest of the world has taken a hard look at healthcare and realized that there are a lot of inefficiencies in the historic system. And so that inefficiency is interpreted as opportunity, and that opportunity is pursued by new market entrants. As a consultant, I've been a strategy guy. I've been talking about disruption and new market entry for a long time. I think now we're really fundamentally seeing it, particularly in the physician space, but also somewhat in the hospital space, and the emergence of these vertically integrated organizations. While the jury's still out, I think we have to be prepared as legacy industry participants to be able to compete in a very, very different, more technology-enabled environment. We also live in a world in which the institutions that we have grown up with are trusted less by the citizenry that they serve, and that eroding trust in hospitals saps the political, social, and emotional capital that we have enjoyed over time. While we had a huge uptick in those areas during the pandemic, it's pretty evident, I think, that that type of support has quickly evaporated. And then if we flip to the next slide, not to put bad news on top of bad news, but your rural hospitals, the challenges are only amplified, right? We're working on a smaller base. We have a smaller N of volume given the size of our communities and the size of our population. We have, a much more thinly stretched leadership group. We don't have layers of management that can work on multiple issues all independently of one another and come back together. Folks are doing multiple things and wearing multiple hats at all times. And there is the promise of, I think now it's a promise when we listen to either the federal government or commercial payers speak, that there's going to be fundamental change. And that fundamental change is going to continue to exacerbate the gulf between rural and non-rural healthcare, and figuring out models for how we go forward and how we maintain our levels of historical success is going to be our challenge. So why service lines? Well, I think all the way over to the right-hand side of this slide, it is about differentiating. And it is about how do we carve out a place for our organizations in the marketplace that is going to allow us to continue to serve the communities that we serve, and to do so in a way that is financially sustainable. We think there are, as the currency of healthcare differentiation changes, we're talking about access, we're talking about experience, we're talking about cost and affordability way more in today's environment than we were 10 or 15 years ago. If we had tried to get a health system to focus on, cost and quality 15 years ago, pre-financial crisis, we would have gotten a pat on the head and said, yeah, boy, that's interesting to think about. But now we're starting to be measured on those things. So times have truly changed. And what we do believe is that we are going to need to meet our markets where they're at, and we're going to need to demonstrate differentiation to those markets on the things that they value. And many of those things you can see are listed on this page in terms of the characteristics of what can be improved by developing a service line, clinical service lines. It is a broad continuum, and figuring out, particularly for rural hospitals, where we fit in that continuum, in that ecosystem, as we call it on the slide, is important. This is a difficult slide for me to kind of think about it as we put together, because I recognize that there's only a point on the horizontal axis for each one of the entities that we've listed here. But when I look at the critical access hospital or rural hospital where it is, we're responsible not only for that single point on the 2x2 matrix. We deliver a lot of care that is encompassed by those other elements of the continuum, given our role in our community, given the lack of services in many cases that are available in those communities, and the fact that we provide really all of them from the front door all the way through the referral to any major referral center. It is a big lift that we recognize you all are being asked to make, and it is something that we're hopeful, again, through focus and through some disciplined planning, that we can help to shore that position up and make sure that we are going to be able to continue to successfully serve our markets. Now, one other point about this slide is, given all of these different points on the map, on the continuum, if you will, this future is going to be about partnering. It is not going to be about how are we going to access technology and hire subspecialists and figure out how we create a world in which we are the center of the service line universe, but it's going to be about figuring out how we participate in the network and in the natural ecosystem of a given service and do so successfully. We think there are a lot of things that the rural hospital can be responsible for. It's about keeping patients in the community. It's about raising the level of our game and the acuity of service that we're able to deliver. But doing that is going to, in every likelihood, I believe, is going to need to be done in partnership with other organizations, whether they're independent organizations of our own or whether they're part of the broader network that we may be a part of already. We've been talking about differentiation the entire time. I think I probably mentioned a whole bunch of these things throughout the course of what we're talking about. The important thing probably here at the bottom of this is, again, what I just said about being, of a partnership mindset. We do not live in a world, I don't believe any longer, where we can be all things to all people as any individual organization. And so the mindset shifting from one, I think in healthcare, which has traditionally been control, to network and adaptability and partnering is going to be a critical step and a critical part of any success in the future that we're able to have. It all starts with design. There is a process, and again, as we have worked with organizations around figuring out what it is we want to be, how it is we want to serve our communities, at what level, there are discrete steps in the process, and it's helpful to make sure that we've got a good answer for the questions that arise at each one, from developing our vision and our direction, all the way through populating our care teams and engaging with our patients. This set of services, again, it's not one thing. It spans a continuum. It's got a vertical and a horizontal dimension to it, and it's got to be done in all likelihood, again, with us fitting in and playing our role in the continuum in a way that makes sure that those emerging currencies of healthcare, access, affordability, experience, are delivered consistently and at the highest level. So yeah, I think differentiation, essentiality, words that we use to indicate what it is we're trying to convey to our clients, what it is we believe that providers need to convey to their communities. If we can look at ourselves and say we are essential to the patients we serve, to the purchasers in our community, to the physicians, to the payers that serve this community as well, I think we can have a very bright future. That future may need to be more focused, but I think there is still opportunity for legacy providers, service lines being one of the modes of differentiation, to continue to serve their communities and serve them well. So with that, I will turn it over to Emily to talk through our approach.
Yeah, thanks, Brian. What we know is that one of the most challenging parts of developing a service line strategy is just knowing where to start. And particularly when you think about such a strategy in a rural environment. So the process that we're walking through today is really designed from the bottom up. So it pushes you to prioritize and focus on those few areas that will give you the biggest impact. So this really becomes an exercise in better understanding how to use limited time and limited resources to identify an impactful solution as you think about service line. So I'll start with an overview of the process, and then we'll get into some of the tactical and nitty-gritty details on these 4 steps that you see here. So the first step, and really the quickest way that we think to get to the crux of what your community needs, is to talk to your primary care providers. So rather than starting with an onerous or a resource-intense market assessment, we really recommend allowing the physicians to tell you where to begin, point you in the right direction, narrow your options, and really start to identify those systemic needs in your specific patient population. And the goal here is to take that feedback and funnel it straight into step 2. So step 2 is really to begin verifying the feedback identified in that step 1 with the physicians with market analysis. So using as much as possible existing and easy to find, easy to navigate resources to help validate market demand for the identified services that you learned about in step 1. And really, because of the sequencing here, you're able to cut out any unnecessary analysis because you've got a narrowed focus after step 1, after you've had those conversations with the physicians. Step 3 is really to assess your organization's capability to deliver and coordinate care along the continuum. So we'll provide some tools for you to help think through how you, and as Brian mentioned, potentially some strategic partners can build a service line around the needs you've identified in your community. And then in step 4, we'll really just pause to address the financial feasibility of any remaining options that you've got on the table. And of course, there are a ton of elements to consider in financial feasibility. So we're going to point out the ones that we think are the most important for you all to consider. And the outcome of this process, of course, is your short list. This is your list of viable service line options that you believe you can provide and provide well, that meet the needs of the community, both providers and your patients, and that we believe is financially accretive to your organization. So we'll break down these steps just a little bit more deeply individually. Recognizing the time and the resource constraints that you have, it becomes valuable to really triangulate as quickly as possible on what the unmet needs are in your community. So spending time and energy discussing and analyzing and building plans around services that will make a big impact. So to that end, we really believe that your biggest asset as you embark upon service line development is going to be your primary care base. So once you've decided to begin evaluating service lines for your organization, you'll want to schedule and conduct some open-ended discussions or interviews with the primary care providers in your community. And these sessions don't have to be and aren't intended to be prescriptive. The ideal outcome is organic lists of pain points and access challenges, gaps where a coordinated service line could really help enhance the care delivered in your communities and the care that's delivered locally. You're going to gather a lot of intel here that will guide all of the subsequent steps in this process that we'll walk you through today. And beyond just gathering insights from the physicians in your community, you're really taking the time to generate their buy-in for any potential service line solutions that you intend to offer in the community. So really, you're coming away from these discussions and these conversations with clarity on where the opportunities are, but also really a better understanding of whether those providers would refer patients to you if you effectively filled those gaps that they have identified. And once you have all of that information, you're going to want to start to validate the market demand with publicly available data that is accessible and easy to digest. So, a few examples of that might be community health needs assessments. There is state and national data available for consumption in most areas, and census data as you think about demographics and insights there. And because you've already narrowed your focus after step 1, discussions with primary care providers, you're really able to take a targeted approach in step 2 to the analysis. The intent here is just to ensure there's enough juice to squeeze from a volume perspective as you think about your service line development. And if you think back to the volume graphic that we just walked through at the beginning of this section, we start with many options and we start to pare them down as we work through this process. So after step 2, the goal is that you can begin to cross a few of those options off of your list based on what you can and can't validate with market demand data. And from there, we move into step 3. So in step 3, we really start to turn our attention from the market landscape back to our internal organization to spend time identifying, building, and really visualizing what that care continuum is going to look like for the services that we're considering. As I think about step 3, it begins to answer the question of what's in and what's out. So what can we provide and provide well locally, and where do we need support potentially from some strategic partners? And so by way of example, we've included a sample care continuum here that through endocrinology. So along that care continuum, it's organized around a common set of services. So it ranges from prevention and risk assessment all the way through post-treatment and recovery. And you'll notice there are certain core resources and core team players that are necessary throughout that continuum. That includes the primary care team, your clinical pharmacist, your care coordinator, and those individuals are supported by a team like community screening and outreach clinics, the endocrinologists, your dietitians. And as you think about doing this in the rural environment, service lines are going to look different than they do in urban and academic settings. And so here your core team is really going to lean more heavily on the primary care provider as the quarterback. Marcy, did you have anything to add on that one?
No, I think that, says a lot of the, key points here. One area that I don't know that we develop or focus on as much as possibly we could, though, are really thinking about that quick care coordinator or patient navigator as being, again, part of that core team. And sometimes we think about them as the quarterback. And why that feels so much more vital in a rural service line to me is that because you're going to likely be collaborating with others in the community, others at a tertiary hospital potentially, having someone that is really part of your program that is quarterbacking that patient and making sure that someone is really helping to ensure the patient is getting access to their care at home as much as possible and has that goal and that centeredness around that patient's care continuum will really help to accomplish what you want to from a service line, which is developing and delivering as much care as you can close to home. And if they have to go out of the community for some pieces, you have that individual that's right there with the patient to help facilitate them making their way back for the other pieces of their care continuum when they're ready for them.
Yeah, absolutely, Marcy. And it does get back to the importance of that step one and aligning your goals with your primary care providers too. Just understanding that they've of course got their hand in a lot of buckets across this continuum of care. And at this point, it becomes really important to start thinking about your organization's capabilities to deliver and differentiate on services across this continuum. So we've outlined just a few programmatic elements for you here on the screen. So some of the things you're going to want to critically evaluate are things like physician and staff capacity, support services, access, space capacity, technology, quality. This is all to determine where you can add value. So particularly in the rural setting, you might not be positioned to provide all of the services necessary for a really robust and coordinated service line. So this helps determine what you can provide and provide well, but also becomes a sort of gap assessment to identify where you might need support. And so from there, we can identify where, like I said, those gaps might be that can be filled with strategic partnerships. And Brian teed that up perfectly in the introduction. Really developing strong relationships with partner hospitals will become critical to the delivery of these service lines. And important to start thinking creatively about access and how we can deliver this care in a really cost-effective way. And so as the rural provider, you might offer a partner hospital, increased patient volume, greater geographic reach, in many cases, more cost-effective inpatient care for those lower acuity patients. And in return from a partnership, you might get things like specialist access, training and protocols, best practices, back office support, and sometimes brand recognition that you need to develop your target service line. And also important to note here, and I know Marcy will give us an example of this, but your partner organization might be a peer, so another rural hospital or a critical access hospital. It's not always going to be your academic or your urban player in the market, but encourage you all to look at all of the possibilities from a partnership perspective. And there are a lot of different areas where you might consider partnerships. So that, could be protocol development, curbside consults, social determinants of health and support addressing those. And for all of them, you'll want to start to put together workflows and messaging just to limit any out-migration and preserve local care where it makes sense. And finally here, based on all preceding evaluation steps, you'll rank any proposed service line options that you've got left on a scale from 1 to 5 on really a range of evaluation criteria. You know, what we show here is intended to be simplistic and illustrative. So you're going to have to think about these metrics in more detail here, even considering assigning different weights to them as you calculate a composite score, just based on the nuanced preferences of your organization. But just to spark some thought, have included a few here like physician support, market share potential, partnership potential, differentiation. You know, your resulting composite score here will really help to determine how you can sequence and prioritize the service line development initiatives that you've got based on their overall viability for your organization specifically. And this will determine which service lines we push forward to step 4 for financial feasibility evaluation.
I am going to see if I can't take over the remote. So thanks, Emily, for that prioritization. And what you probably noticed was not on that prioritization matrix, but we all know would be on there ultimately as you continue to move your way through that funnel and look at your different options is, you know, what is the feasibility? What's that financial feasibility of that service line? So we've narrowed it down. So maybe we're down to 4 service lines that seem to have physician support and buy-in, look like opportunities to actually, you know, generate some volume and some market share, have opportunities to partner if need be, to be able to complete that continuum. But if we can't generate a positive financial return, then it's probably not going to make sense for us to invest in that. So we really need to think about what are the assets, what are the revenues, what are the liabilities, what are the costs for us to develop this service line to make sure it's something that we can actually accomplish. So we listed here, you know, we're not going to kind of walk through how you do a financial feasibility, but we did want to just point out a few considerations on the revenue and cost side. You know, so first and foremost, when you're quantifying the volume potential, the associated revenue and costs, you really need to make sure you incorporate that complete picture of the service line definition. So you understand that full continuum of care. As Brian mentioned at the beginning, what are the things that occur in the service line on the inpatient side, but then as you move into the outpatient side, as you're moving into supportive services and all of those pieces, how do we understand that full picture? This may mean you need to develop a different report for understanding that service line than you're used to. A lot of times at hospitals, if we do service line reporting, it's typically everything is sorted by DRG, and we've got our cardiology and our ortho and our neuro and the big hospitals, et cetera, and women's services and all of those things. But ultimately, a lot of service lines, when you're looking across that full continuum, you really need to start thinking about things like the diagnosis or the procedure codes and define them a bit differently so you truly are capturing that entire experience. You really also need to think about whether you can price the service competitively to attract your patients, but also importantly, attract those payers. If we can't deliver that particular service at a price that is comparable or better than our competitors potentially, we're going to have a really hard time telling the payers that, you know, you really need to have us in your network. So those types of things need to be looked at. And now we do have this price transparency data that everyone is generally expected to report out that can sometimes help with some of these, but we all know that hospitals do what they can to make that data very, very difficult for us to use and look at. And, you know, we've developed a price transparency tool to try to take some of that at PYA and aggregate it so that we can see some better pictures for it. But at least those main shoppable services, you can often kind of look at some of those and see if our price, after we consider all our costs, that we would be able to be in that ballpark with some of our competitors. Understanding your current payer mix. And developing that profitable payer strategy is absolutely important. We know it's difficult to make money on Medicare, Medicaid, and of course, we're not making money on our charity patients. So our commercial payers really need to offset any of those losses that we experience from our other payer groups. So we have to be sure we understand how these payers are impacting both the inpatient side and as well as the outpatient payments for that care continuum for a service line. And you also may want to consider leveraging any self-insured employers that you might have in your community to negotiate rates with some of these commercial payers to help cover those costs. You may have some opportunities to really collaborate with them on this. And if you have access to things like 340B, well, that can afford greater capability to generate return on some of these service lines, such as your oncology service line or specifically focusing on infusion therapy. And you may also be able to use this to leverage partnerships with others. As Emily was saying before, maybe you can develop that service line and then be the provider of that service for your peer, your other rural community hospital down the road to really let them take advantage of the opportunity to use your 340B services, or even sometimes that tertiary hospital. They may be getting all the commercial business. They may not actually be able to tap into 340B and may find significant value in partnering with you so that those patients can have access to more affordable drug pricing for their care. On the cost side, we're not going to get into the details on this, but just always make sure you considered all the relevant operational costs and the capital impacts, professional services, technical services, all of those things. But then don't forget that while it may look like the cost sides outweighing that revenue side, this is where some of those partnerships can come in that will help optimize your investments, will help to streamline what you're paying for and what others are helping to share that load across the continuum. So as I mentioned, that there really is a close relationship between the volume of payments for rural hospitals, and we can't overstate the importance of understanding that payer mix impact on your financial success for the service line. So we created this little illustration just to kind of bring home the point that, right now, for example, if all you're treating are Medicare patients for your service line, you might break even because the hospital's getting paid approximately 100% of those fixed and variable costs for Medicare patients, which, is good. It keeps you in business. But here's the challenge. If you decide to develop a service line because you really want to double size your program with commercial patients, because commercial is ideally where we're going to generate some more of that return. But what you need to recognize is that if you double that size by adding the commercial patients, the Medicare payment per patient will get diluted, because those fixed costs that previously you might have been getting $100 per patient for, now when you've doubled your patient count, you're getting half of that. So now you're only getting $50 per patient for that. So now your commercial patients, they have to pay more than Medicare to ensure you're getting a profit. And in some cases, with some programs that we're seeing, that's not always the case. Sometimes these commercial payers are just not willing to pay enough to cover the costs. They're pushing back at everything, and we really need to be crystal clear. What are our costs, and are those commercial payers going to cover us for that? Because if you don't know the answer, you may find you're growing, but then your commercial volume isn't generating that return, and you may end up with a net loss with that program. So it's truly critical that we spend that time and truly understand how our payment's going to ultimately shake out. But lastly, just don't forget, we also have alternate funding sources. We talked about working with partners, finding ways to share in the service delivery and with the cost of some of those services as well. But we also sometimes have access to philanthropic or grant funding, and those can be great tools to support capital investments and any non-revenue generating programmatic and operational costs. These are critical for service line development, especially, not just if you're going to create new space to deliver that service or you need new equipment or technology, but it's those supportive care services that we talked about across that continuum. A lot of those don't get paid for. Patient navigators, rarely can we charge for those services. Care coordinators, educators, a lot of times we can't charge for that. These are opportunities where we can look at creating sustainable grant funding, sustainable philanthropy to help ensure that we can truly deliver that full continuum. So now we just want to share a few case studies with you. They're not necessarily going to kind of roll out exactly the process that we just described. A lot of programs, they jump into developing these services, where they can. Again, people try to find the time to develop the service lines with, their current teams and don't necessarily process things this way. But we did want to share some successes that programs have had with developing different service line approaches, so we can think about those and how to bring some of this experience towards our assessments as we continue to do them. So this project here, well, we're talking about the endocrinology service line, but it was initially started as a rural heart and stroke focused initiative, and it aimed at creating a collaboration between an academic medical center and all the statewide rural hospitals to enhance access and ability to manage diseases such as diabetes or endocrinology within the local communities. So in this collaboration, the hospitals, they participated in several performance improvement initiatives, and they also pursued strategies to reduce that total cost of care. So not just how do we build the continuum, how do we do it at a very attractive, a lower cost, so we could then go to payers, set up an ACO, and participate in Medicare shared savings and ultimately other programs. The implementation for this initiative first really focused on developing common care protocols tailored to the rural setting. So while they came from the academic medical center that was helping to provide the guidance on how to set these up, they adjusted them, knowing what it would be like to deliver those service lines in that rural setting. And then they conducted local boot camps to help provide that training. The AMC then monitored the performance with regular case reviews that they did at specific intervals. And all these efforts really were focused on helping to facilitate that appropriate care was being delivered in the local community as much as possible. Then, similar to what other programs have done before, they also layered on some teleendocrinology. In this case, they developed a peer-to-peer access point, so specialty providers could be reached when needed by the local physicians, and these were what they called curb consults. Emily mentioned them earlier. And they also developed monthly telehealth patient-centric clinics as well. So it was definitely a success. They, of course, incurred some challenges that a lot of programs experience. Getting the time commitment from the AMC providers to participate in this was a challenge, and also building trust. So building that trust between the rural providers and the tertiary, that's something that comes with time, comes with demonstration, primarily the demonstration of if we work with you for our patients and we get your expertise, that care remains in the home community. That has to be demonstrated to build that trust ultimately. This next case study focused on service line growth. And in this case, one particular hospital was experiencing significant outmigration of patients. It really was a double-digit decline in some service lines of their patients that were leaving the community, and it was putting a long-term sustainability of that program at risk. So they looked to identify, where can we reverse this trend? And in this case, they started with the market and an organizational assessment, and they identified what their current capabilities were in those different service lines and where were those gaps. Particularly, they really prioritized, though, here, they kind of started out and said, this is where we're losing the patients. This is where the outmigration is, and let's look at those pieces first. And then they collaborated with local physicians to work together to define what approaches can we take to fill the gaps and improve outcomes. But not every service line they identified, there were definitely a lot of opportunities. They couldn't do them all. They had financial constraints. So they prioritized, in this case, orthopedics and interventional cardiology, because they evaluated further the financial feasibility, and they learned that those two programs would generate the greatest return. So they wanted to start out with the things that they could generate return on first, and then they could reinvest some of those returns on moving forward with some of the other service line initiatives over time. In this case, of course, the hospital did encounter a few critical challenges, and particularly, they didn't have enough primary care. This was impacting retaining those patients in the local community in the very first place. They were having to leave to get some of the primary care, and that automatically, has doctors that are tied to other health systems. So they worked really hard to fill some gaps by using APPs to try to meet some local needs. They realized that had to be a priority investment for them. And as they were going through this work too and trying to identify the opportunities and the feasibility, they didn't have a cost accounting system. And some of you all may not have that either. And that makes it really difficult sometimes to identify what are all those costs that are attributed to the service line that they had to kind of work around and try to make sure they understood enough about those costs so that they could truly get a good enough picture of their return on their investment. These last two case studies, they're very brief and they're really focused on particular services. In this first example, there was a local physician practice, and that physician reached out to a local critical access hospital and said he couldn't deliver the infusion services in his practice any longer like he was, and he wanted the hospital to take it over. So in this case, the critical access hospital reached out to a nearby tertiary hospital to help them set up a local infusion center. And they used a third party to help evaluate the volume and the revenue potential of what to expect when they did so. So while they had the tertiary hospital provide that expert guidance, the critical access hospital took over the delivery of the infusion services, and they used an APP to help do that in the community. It was much more effective for them and accessible for them to have a mid-level help with that support. And then this last example, as Emily mentioned before, this was an example where a rural hospital, they just needed access to higher quality coding support. They didn't have it. They had a third-party vendor they were working with, and they were unhappy with that vendor. They weren't providing the service that they wanted. So in this case, instead of going to a tertiary hospital to find that support, they went to one of their peer hospitals, another critical access hospital in the region, and they were able to work with them to get remote coding expertise. And it ended up actually being a win-win for both hospitals. The other critical access hospital that had the services available, they were struggling to keep the full-time coding staff in place because they didn't have enough volume. So now they had the staff busy enough to keep someone in place full-time that was doing a great job, but they were also able to help support one of their peer hospitals in the community get the quality coding they needed. So we have more examples of this and case studies, and we're happy to share them, at another date. We can share them offline if you want to reach out to us, but we wanted to save room for some question and answer here. So really just to kind of wrap up what we've been talking about today, we know service lines, there really are a natural approach to differentiate our hospitals in what is continuing to become a more and more challenging healthcare environment. After all, our patients, they have a particular disease and they'll seek access to what they need across that whole care journey. Typically, they want it from one provider or one health system, and they don't want that fragmented care, and they do want it as close to home as possible. But the challenge for us is to determine what service lines should be a priority for your hospital to develop, considering the volume potential, considering your existing and potential capabilities, and also that financial feasibility. Can we get the revenues to really support the cost of delivering that service? And your local physician community, particularly your primary care, they are key, absolutely key in helping to efficiently determine what's the low-hanging fruit. Where do they see the greatest areas of opportunity, and what patients will they choose to refer locally to the services if you take the time to develop them? If you develop something and they continue to want to refer out of the community to some other providers that they had a long-standing relationship with, then you've made a really significant investment and you're not going to generate the return that you expected. So getting that buy-in and collaboration with your local community physicians is really critical. So with this knowledge and with really thoughtful effort, again, thinking about that care continuum, making rational investments and strategic partnerships where it doesn't make sense for you to directly make those investments, rural hospitals can establish financial feasibility, and you can develop that quality service line that has the patient experience, that has the right total cost of care to be successful. It'll be what payers are willing to support, and of course, what your patients will want to stay home for. So thanks for giving us an opportunity to present to you today. I hope that you found this valuable, but we want to spend some time. If you would like to answer any questions, we would welcome them.
Thank you, Marcy. I'm checking the chat and I don't see anything, so we still have plenty of time. We have about 10 minutes left on the webinar. If you have a question and you want to drop it into the chat box, you can also select my name from the drop down, Cassidy Avila, and send it to me directly, and I'll be happy to ask that on your behalf. Don't want to share with everyone, or you can unmute yourself. And I will give you just a moment to kind of gather your thoughts and type out your question. And I'll just remind anyone that did not hear at the beginning of this webinar that we are recording, and we will be sharing the link to this recording as well as a copy of the slides. Give us 24 to 48 hours to get that posted to our site, and then you will receive an email from us. And I know we get that question quite often in the questions. So. Don't see anything coming through chat. But Marcy, that was an excellent presentation, and we appreciate the case studies as well. And unless you have anything else that you want to add, I think we'll just go ahead and adjourn. I see a few people dropping off the call, probably getting back, going back off of their lunch break and starting the afternoon. So I think we'll go ahead and adjourn unless you have any final thoughts, Marcy, Brian.
No, I think we're
thank you.
set. But thank you for the opportunity. You all can see our contact information there, and it'll be, of course, in the recording of the webinar. So if you have any questions offline, or if there's any more detail we can provide to anybody, please don't hesitate to reach out anytime.
Yeah, absolutely. Contact any of these individuals at PYA or come through us, and we're happy to connect you with someone if you like, or if you think of a question after the webinar, don't hesitate to reach out. Marcy, Brian, Emily, thank you so much. We appreciate your expertise and your time, and we'll be talking soon. Thanks, everyone.
Thank you.
Thanks, Cassidy. Thank
Thank
everyone.
you.